Hi, this is your Houston chiropractor, Dr. Gregory Johnson, and today we're going to be showing you how we treat a patient who has had a severe ligament tear in his ankle that is so bad that the orthopedic surgeon actually had to put 2 screws through his first 2 bones, the tibia and then the fibula, to hold it together. And I'm just going to bring it up here so you can see the actual x-ray. That's the pins, and as you can see, this long one right here is actually sticking out of the bone into the skin, which he's having a great deal of problems and pain with. So Sonny, why don't you come on over here. Now, he's been walking around on these crutches now for how long?
3 months.
3 months. So he has severe altered ambulatory kinetics, of course. But he's also getting what's called compensatory kinetics in his spine, which means he's getting subluxations or misalignments in his knees, his hips, his pelvis, his spine, all the way up into his skull. And there's something wrong up here too, but we're not sure about that yet. Okay, don't worry. We do like to have fun with our patients, and they're all good about it. So you checked my reflexes the other day up there, and they weren't too good either. So all right, so you're going to find here that whenever we're treating patients with this severe of an orthopedic type of problem, that we want to be as aggressive as possible, but we always want to work with the orthopedic surgeons to get the right results. And actually, we just got him into a sports medicine orthopedic surgeon recently who's going to take these pins out, because if he didn't take them out, they would be a permanent source of irritation and pain. And so anyway, I'm going to show you exactly what we've got going on here. The right leg is short by 1/2 inch, of course. Now, as I bring it up, you'll see right there already it gets even. Now, watch his pelvis and low back right there. Doesn't raise and twist as much as it used to, but I want you to look at this foot. See, that's very painful. And look at the difference in the range of motion on this one. Now, also, this one going this way versus, look at that. I mean, so there's a tremendous amount of pain and dysfunction in the affected foot here. Now, he's got pain also in the gastrocnemius, or what most people call their calf muscles. Feel those knots right there, pretty sore. And then he's also got swelling and pain down here. Now, we're not rubbing on that area down there to get rid of the toxic metabolic waste products like you see me doing on a lot of people, because the actual pin's sticking through it, and it actually is very painful when you touch the edge of that. It's like a nail sticking out of your skin. So what we're going to do is we are going to palpate his spine, which is what I do with my fingers. He's out right there, all the way through here, and way down here in his low back and pelvis. Now, I'm going to let his head down just a little bit to open the joints up. But we're going to start with the right sacroiliac joint. Now, he has his internally rotated, and it's also elevated. That's why this right leg is shorter. So you're going to see me adjusting in the x-axis, the z-axis, but also now into the y-axis. And you're also going to see me with dual contacts. One's on his superior sacroiliac, the other one's on his ischium, right down here, and then his actual hip joint. Now we adjust the actual sacrum, which is the middle triangular shaped bone in the center of his pelvis. This is the left sacroiliac joint, and you notice how I'm doing this one differently. And I've got one more on the X and Z. Now, that helps us already get a better configuration here at L5. Now, that one is a straight P to A in the Z-axis, posterior to anterior. Because when the vertebrae slip backwards, that's where the nerves are, and that's where the pain comes from. Pinching on the nerves as they exit between the vertebrae. And I want you just to breathe normal here. Now, because he's been walking around with these crutches for 3 months, his paraspinal musculature is very, very tense. We call that hypertonic. Now, I'm actually going to be using a technique where I'm going to be putting my elbow on his paraspinal muscles and sliding up. Boy, you can feel those, huh, Ted?
Yeah.
Right, all the way through there. Now see, there's just knots all the way through his entire spine. And he has what's called a great deal of fixation or lack of mobility in these vertebrae because these muscles have been in such spasm and guarding because of him walking around crutches for 3 months. It's affecting not only his upper back and his neck and arms where he's on the crutches, but it actually affects all the paraspinal musculature from his skull all the way down into his lumbosacral spine and sacroiliac regions. Now, we just did that, and we check his leg length again, and looky there, it's exactly even. We bring it up, and it stays even. How'd that feel compared to the first one, Sonny?
It's good.
Very good. Now, you are going to see me doing some adjustments on his feet, but I do them very... Now, you felt that, didn't you?
Yes, I did.
Very good movement right here, but we're doing this gently at this point in time because he's got a buildup of scar tissue down in here. Now, you're going to also see that I'm going to work on the base right here, which is the plantar fascia. Very painful down here, too, just from walking around cockeyed, limp, altered ambulatory kinetics. And then we're going to grab that little piggy and that little piggy, and we're going to get all these little piggies lined up so they can go wee, wee, wee. See, you almost went wee, wee, wee right there. Now, this one's not near as bad. He's got a little bit here. But see, I can adjust this foot a lot easier without as much pain, right? Now, see, this guy here, though, whew, big knots here. So I'm going to pull out the Terminator, and we're going to start in his calves, not his feet yet. And I'm going to be getting in there, and this is very painful at first. And with his hamstrings all the way up to his ischium or the pelvis, the IT band or the tensor fasciolata up into the gluteus maximus, medius, and then way down deep there is the piriformis. And then we're going to do the identical thing on this left leg, calf first, soleus muscle. I call this my human meat tenderizer. This is actually called the Terminator and was built and designed from a friend of mine in California, Dr. Bart Semrek. And these are available to healthcare professionals that know how to use them, but as you can see, they get very deep and it's very hard. So you want to make sure that you know what you're doing, and you want to stay on the muscles only, never get on the bones. This is actually causing the muscle fibers, the fascia that covers the muscle fibers, to relax and release, influxes blood, carrying oxygen and nutrition into his muscle cells, and also it helps to relax the muscles enough to where the blood can actually carry out the metabolic waste products of normal cellular metabolism. Now I'm going to have you scoot down this way just a little bit, Sonny. I'll put that up for you. There you go. Now see, we have to scoot him down on this one because too much stress on that foot when it's touching the table is very painful at this point in time. So we're going to let him leave here with a lot better feeling than what you have when you get the Terminator, which is very deep muscle work, myofascial release work. And same thing on the lateral aspect. We're doing the tensor fasciolata, the IT bands, And again, getting down into the calves. But you notice that I'm doing the entire foot, and I put it in flexion and do it, but I don't put too much stress and strain in there right now because he's still got the pins in there, which we hope to have being removed in the next couple of weeks. Once we get those pins out of there, I can get much more aggressive on his rehabilitation and get him walking with a normal gait. That this will help his entire spine to then hold the adjustments for a much longer period of time. You like this a lot better, don't you?
Yes, I do.
That's the common answer we get. Now sometimes we actually use that terminator on people, and they actually even scream when we hit some of those trigger points because they're very tender. So there, we got him a good rubby feel good on that one. Increasing the circulation, carrying out metabolic waste products. So scoot you all the way up in here now, Ted. Now, because of him being on those crutches all the time, you can see he's overdeveloped his latissimus dorsi muscles, and we've got subluxation right here. There it is. I'm sure you heard that one over there. And I'll shut up so you can hear him. There we go. Moved great on both sides, and my thumb was contacting right at T1, T2, and I did a contact on his occiput here that we got movement all the way from C7, T1 actually, to all the way up to his skull or the occiput. But see, he's got these huge knots and trigger points in here that we're still working on. So let's go on your back for me now. And he's actually getting around a lot quicker than he used to. He's moving about 3 times the speed that when I first met him. Now, again, what we want to do is we always want to do things bilaterally. Now, see, I've already got movement in some of these, but you notice when I put them in different positions, I actually get different movement. Now, look there. We got some pretty good symmetrical internal inversion, we call this. This is eversion. Now this is much harder. See how this one doesn't evert? This one hurts worse, doesn't it?
Yeah.
See, this is where he's locked up with that pin, and I'm not going to poke on that pin. But the tibialis anterior, which runs from the femur all the way down into the ankle, is involved. So we're going to work on the muscle spindle and Golgi tendon apparatus on both sides here. We're going to trick them into relaxing. Now, this one is very important on him. I'm adjusting his talus, and he'll feel that all the way up into his pelvis. Now, on this side, of course, I don't do that one as hard because we still got those nails and pin screws in there. So we're going to take it easy on that one for a while. Hopefully not too much longer, though. You know, when we get started with the real rehab, he'll really be screaming. Everybody would be, including myself. I'd probably be screaming too. Alright, now, we're going to move up here and we're going to do a Palmer package diversified cervical adjustment on his atlas and axis. Right there on the right. Boy, that went perfect. Same thing here. Yes, sir. Very good. Now, what I'd like you to do, Ted, is scoot all the way down for me so that I can do your shoulders. Now, this is very important for his scoot down just a little bit more. Now, they straight back. This is very important for him because being on the crutches has created what's called a forward head posture. You can see a ton of stuff in the literature about that. But it's also created a little bit of rounding in the shoulders. So, what we're going to do to correct that is we're going to put his arms out, and I'm going to be adjusting his acromioclavicular joints, his claviculosternal joints or sternoclavicular joints, his costal sternal joints, which is where the ribs meet the sternum in the front. And we do that on the z-axis as well as the x-axis. Excellent. Very good. Now, let's sit you up sideways and face towards your neck there. Good. Now, we believe that an individual is three-dimensional. Mind, body, and spirit. So we adjust every joint in the body that we can. Reach. There we go. Both shoulders went really well. Elbows right there. And see, because he's holding on to that crutch there, he gets a lot of that wrist stuff too. So, and his fingers are really stiff right now. And they've gotten stiffer over that time frame, huh? Yep. Now, very good. Yeah, just let this one go. There we go. Excellent. I'm sure you're probably hearing all that, especially when I quit talking. There we go. Good. Now, I'm going to give him his crutches because I really don't want him on weight bearing yet, like that. So we're going to come back over here in front of the mirror. I'm going to be adjusting his cervical spine, the atlas, with him in a mirror image, even when he's on his crutches, so that we can retrain the cerebellum to hold his spine in place as opposed to this out of place position. Now I have my trusty atlas adjusting instrument, which was also designed by a friend of mine out in California, same guy. Now close your eyes, flex your head forward all the way. Excellent range of motion. Now, as you can see, look how far his head's gone down forward. That's the forward head posture that we're talking about. And his shoulders have squared off quite a bit since we started, so they're not bad, but the left shoulder's quite a bit higher. And in looking at him, his pelvis has shifted way left, so we're going to have you lift your shoulders up and back. And then I'm going to physically bring his head back in the Z-axis. We're going to translate him this way. And I want you to shift your pelvis straight right for me. And let me have that chin all the way back. I got you. I won't let you fall. You can lean on me. Now, a lot of times, you actually have to hold patients up on this one because you get into some very precarious positions. Now, we just adjusted him bilaterally in his atlas, got information into his cerebellum. Let's have you flex forward and backwards again, eyes closed. Look at the difference already in the range of motion, back to center. Much better. His chin's up more, but see, we still got some work because he still has that forward head posture. Where ideally, we're going to get him is like this. Now, this may feel really weird at first, but now when gravity's pulling him down to the earth, his joints will be holding him up rather than all the paraspinal muscles and his disc. This is your Houston chiropractor, Dr. Gregory Johnson. We'll see you next time.